Hey, good morning, everyone, and welcome to the show. This is UroNurse. I'm your host, Vic Sinise, and welcome to joining us. If you're coming to us on the live shows, we come to you from YouTube, LinkedIn, Facebook, and X. And of course, we're always having StreamYard viewers watching us, so great to have everybody on live. This is your first time checking us out, though. Go to uronurse.com to learn more about the show. And it's the best place to go to catch all of our past episodes. And we have 122 of those episodes out there. And also, you want to catch us on your car. Maybe you got a long commute like I do. Go ahead and check out our UroNurse Plus area where you can go ahead and load up our podcast on any of your favorite podcasting apps. Hey, just in case you weren't aware of it, we actually have 3 podcasts out there. UroNurse.com, UroPatient.com, which follows this show at 10:30 Central Time. And then once a month, I've been doing Streaming Boot Camp. It comes out the first Wednesday of the month, and that's at rotkiv.net. Weird name, right? Rotkiv is Victor spelled backwards. And little teaser, coming January 7th, there's going to be a 4th podcast launch, so wait to see what that is. I'm real happy to have Dr. Landon Trost joining us this week. He's been on our show before. He's got a lot of new information to share with us. So we're going to go ahead and bring everybody on the show right now. So welcome to the show. And Andrea, welcome. We got everybody now. There we go.
That would be Lori.
Lori.
That's okay.
So you threw me off. I had to sneak you in at the end.
I know. I snuck it at the last minute. Sorry.
Well, go ahead and give us your introduction, Lori, since you're here.
Hi, my name is Lori Atkinson. I'm a certified urology registered nurse. I have been in urology for 26 years now. Currently working at Northwestern Medicine in Geneva and Winfield, Illinois.
All right. And I'm the host of the show. I've been in urology for the past 40 years. I just started getting some stuff on LinkedIn where people were saying, congratulations on your anniversary. I didn't know my business actually put something on LinkedIn about my anniversary is in December, and it has been 40 years with that company. So yeah, it's true. I'm old. All right, let's bring in our guest host, Dr. Landon Trost. Give us a little introduction and we'll get the show going.
Well, good to be with you. Yeah, thanks, Vic, for the invitation again. Lori, good to see you again. And again, I apologize for the background here. I'm actually kind of hiding in a closet right now. This is my most reliable internet. Almost guaranteed you'll see the kids pop in at one point or another here. But it's about as good as it can get. And I figured to make up for the bad background, I figured I'd throw a suit on for it. So yeah, I'm Landon Trost. I'm a urologist specializing in sexual medicine. As far as background, I previously was the chief of andrology at Mayo Clinic and was there for about 12 years total. And my wife finally said, you're too busy. You got to change jobs. And so I opened up a practice in Utah, and we specialize in male infertility, things like vasectomy reversals, and then Peyronies disease. So we're real niche. I've stayed academically involved and continue to try to publish studies and, remain active that way. So, and very glad to be with you.
Great to have you on your show. Let's bring up your slides here. Okay. And go ahead and switch there. Great.
All right. Well, I'll go ahead and jump in and stop me at any point. So now this lecture, so when Vic and I had talked on this, he was saying that sometimes there's benefit in seeing new things coming down the pipeline. So in contrast to the prior presentations where they've been very data heavy, this one's going to be much more sales-like as far as it's going to show you kind of everything new coming down the pipeline. Now, I'll do my best to not have any sort of sales aspect to it, but we're going to be talking about kind of updates to new innovations that are either available or coming down the pipeline. So along those lines, everything I'm going to present are things that I've developed or invented. And basically in my practice, because I see so much of these as far as Peyronies and male infertility, you just naturally see a need for certain things as time goes on. And so it's been nice that we can develop, whenever we see a need, we develop a product that meets that need. But so just realize there's going to be a high risk of bias because these are all things that I've developed, and I'm a part owner in Pathright Medical, which is kind of the arm that lets me develop these. But I did put my ownership in that in a blind trust to try to minimize COI as much as possible. And then from an academic standpoint, I'm the president-elect of the Sexual Medicine Society of North America, the editor for the Journal of Sexual Medicine. I'm on the American Board of Urology Exam Committee, the AUA Patient Guideline Committee representative. Endopharmaceuticals, I have a couple grants with them, but I don't receive any PI or personal funds from it. And I'm not speaking on behalf of any of these entities, which I think is important. So again, these are just my comments and my thoughts on things. All right, as far as outline, so I'll give just some updates on RestoreX. Many who've seen that or run with it before, you're aware of a lot of the information there. But then I'll focus some time on new items. So RestoreXL, SnipCheck, penile meter, and Peyronie's gene. Some of these are things that I'm real excited about, just because they're opening kind of new areas that just haven't been looked at before. And then I'll just comment briefly on some upcoming future plans. Can't share too much there, but we do have several other things that'll be rolling out over the next year or two. Okay, so by way of updates for RestoreX, so, and I probably should have included a slide, what is RestoreX? It's a traction device that we developed for men with Peyronies disease. Traction, just like braces for teeth and things like that, in the body, sometimes you can bend things straight. And with Peyronies disease, it's a condition where you get a bent penis. And so you can use a traction device to help bend it straight, but also to gain length back. So that's what RestoreX is. It was a device we developed, I think back in 2017 is when it launched, or so, somewhere in there. Well, so just as a kind of review, we did a randomized controlled trial in men with Peyronies disease with this device, and basically showed that it did increase length and it did improve curve. So the device worked. People gained about an inch in length when they used it for 3 months. And curve-wise, they had about a 24, 25%-ish improvement in curve for those who actually used the device in the study. And we did find if you used it in a combined manner, so traction or RestoreX plus XIAFLEX, it actually improved the outcomes of it. So XIAFLEX is a drug which was released about a decade ago that dissolves the scar linked with Peyronie's disease. And when you combine that plus something that mechanically stretches it, you get a greater improvement. So here you can see the change in penile curvature. Those who did XIAFLEX, which is the CCH, plus RestoreX, got a greater improvement compared to those who tried to use other devices or just XIAFLEX alone. And that's whether you looked at it from a degree or percent standpoint. And similar to our other study, we saw that those who used RestoreX plus XIAFLEX actually gained length, whereas with the other arms, they actually lost length or didn't really have much of a change with treatment. So it looked like it worked. It improved length, it improved curve, and so that's what it's been used for. But surprisingly, in all of our studies that we've done, we showed improvements in erectile function. Now, these aren't dramatic improvements. It's not on par with like Viagra, Cialis, or injectables or anything like that, but they're improvements. And so guys with mild erectile dysfunction, how many of them met the minimally clinically significant difference, which is basically the amount that regulatory bodies look at to say, this is what is needed to achieve a meaningful improvement. And whether you looked at men who actually used it as recommended or those who may or may not have used it as recommended, we do see improvements. So roughly 2/3 are getting improvements regardless of how severe their erectile dysfunction was. So this was surprising. We didn't believe it at first. We almost didn't even publish it because it just seemed unbelievable and hard to explain. But every which way we looked at it, whether we looked at IEF scores or that prior one that I showed, every subcategory that we looked at, we did see improvements in erectile function. So along those lines, we thought, well, what group of men struggles the most or complains the most of erectile dysfunction? And often it's the post-prostatectomy guys, because one day they have normal erectile function and then post-surgery they have a reduction in erectile function. So we did a big study looking at men post-prostatectomy and had them start traction with RestoreX about a month after, using either 30 minutes 5 days a week or 30 minutes twice a day 7 days a week, and followed them out until 6 months to see what did it do. Did it actually help preserve erectile function, increase length, things like that? And just like the other studies, it did show an improvement in penile length. So here you're gaining about 1.5 centimeters or so in length compared to none in those who didn't do anything. But interestingly, we saw that those who did the device used intracavernosal injections less. Now, these are the meds that help cause erections. And 50% of those who didn't use it were using injections versus 19% in those who did. We also saw a slightly, but not statistically significant difference in use of pills. So a slightly lower rate of use of pills like Viagra, Cialis, things like that compared to those who didn't use it. But importantly, when we looked at erectile function, so this is the erectile function domain of the IEF. This is the gold standard way of looking at erectile function here. We saw that those who used the device had basically on average no change. Now this isn't, I'm going to show a new slide in a second which shows this better, but looking at the data this way, the men were similar to what they were pre-op versus the control men, or those who didn't use the device, had a decline in erectile function, which is what we expect. When you looked specifically at men who had baseline erectile dysfunction, we saw some improvements and we saw some declines. And then it improved some other domains like intercourse satisfaction and overall satisfaction, as you can see. So it did look like it was actually doing something. Now, this is a busy slide, but if you focus on this left one, this shows what I think is a more accurate way of looking at the data. That those who didn't use the device started here, erectile function-wise, higher is better. And then post-prostatectomy at 6 months, they were here. And so this shows that clearly there's a decline, post-prostatectomy. And those who treat men post-prostatectomy, you definitely, even the best surgeons in the world, you're going to see an impact on erectile function. It's just probably not possible to not have some degree of impact. But those who use the device had a much better preservation of function. So they declined from here to here post-prostatectomy. So there's something to it there. Now, to put this into context, it really is a major contribution. When you look at the biggest contribution to improving erectile function, that was nerve-sparing techniques that were introduced. And this was very much popularized and introduced by Dr. Walsh. But since then, there has never been a therapy which has ever been shown to improve spontaneous erectile function post-prostatectomy. In fact, all of the randomized data which has been out there has shown a lack of efficacy of pills. So Viagra, Cialis, things like that. Now, these still improve erectile function, but they don't help preserve spontaneous erectile function post-prostatectomy. And even vacuum data, so again, pills and vacuums, these are commonly used, but even those, the data only shows benefits during use of the device. They've never done a washout study to show if it helps preserve erectile function or not. But despite that, these are real commonly used. So now because of that, we're doing a big study. So we're doing a big multinational randomized control trial looking to see, are these data actually legitimate? Our first study, I forget offhand, but it was about 80 men we had final data on. Now we're looking for a much bigger study, multiple centers, things like that, just to see, can we verify this finding? Now, if anyone wants to refer someone for this study, you do get a referral bonus, and this would be for whichever person refers them. You just have to let us know. And so you get a $500 referral bonus for it. And you would just email research@menshealthstudies.com. So the patient could email research@menshealthstudies.com, say, hey, I'm interested in the post-prostatectomy study. And then we can help get them enrolled. They just have to be referred before 1 month post-op is a key thing. So if you're going to refer someone and they're 6 months out, it's probably too late. It is too late at that point. It has to be within 1 month post-op so they can be randomized to either the RestoreX treatment versus not. Now, the patient doesn't have to travel in. It's all done electronically, and the patient gets reimbursed as well. I can't remember offhand, but I think they get paid up to $600 to do the study, and then they get a free device and things like that as well. Okay, so now changing gears. Those were updates in RestoreX. Like that was all, kind of existing information there that I just, as far as what's new since we talked last on it. Now getting into some of the newer ones. Starting in probably early, maybe March, April-ish of 2025, Pathright is going to release a new device called RestoreXL. And this animation just gives you kind of an idea of what that will look like. So this is the device. It's being fastened to the head of the penis right now, very similar to RestoreX in that way. Similar mechanism, similar benefits on the securing side. But you'll notice it's much smaller. So it has the ability to adapt to essentially all penile lengths. The mechanism is the same, where you can extend the spring, and as it's showing there with the red, there's not enough traction on it, so you can extend it even further while it's in place, and then you can get the benefits of the spring with it. So many similar mechanisms, everything essentially identical to RestoreX, except it does not have the ability to counterbend, and again, it does have the ability to adapt to all lengths. So the nice thing about that is sometimes you'll get men who either due to obesity or due to micropenis, things like that, existing devices just can't adapt to them, but this would have the ability for all men. It's also a lot simpler because it just lengthens, you don't get counterbending, and so it may be an ideal thing for things like prostatectomy. The company hasn't released the final price on it, so I don't know what that's going to be, but it will be less expensive for sure because there's less machinery, less mechanisms, easier to build, things like that. but all the mechanisms are similar. All the data would be expected to be identical to the RestoreX study. And again, probably somewhere in that March, April, maybe even May 2025 is when it'll be released and available there. All right, so another thing that's new that Pathright put out, this is called SnipCheck. So in my practice, we do a lot of vasectomy reversals, and I found that it was very unreliable as far as whether people did the return sperm tests. So we started having them mail in or ship in specimen to us, and this was many years ago. And we found the results were very reliable. Sperm don't degrade or anything like that. And so we were able to get good assessments of their concentration. Well, we thought, hey, if we do that, why don't we do it for all men post-vasectomy? Because post-vasectomy, you just need to know basically are sperm present or not. Because if there are many present, then you worry that, all right, this needs to be followed a little bit further before secondary contraception stopped. But if there's no sperm seen, then these men are cleared and it's a non-issue. So we decided to do SnipCheck. So, and it's, you can find out more information at snipcheck.com if you're interested. But basically the patients get these kits. They collect the specimen at home, which is a lot nicer than, coming into the office. I don't know if anyone's ever had to give a specimen in the office, but it's bad in so many ways. But this you can collect at home. It's then shipped to a lab. And what's great is these are done by manual count. So you'd have to, it's kind of insider baseball a little bit, but there's two different ways that people do these sperm, or maybe three ways or more that people do these sperm counts. One of them is you do it by hand. So you do a microscope and you look at multiple screens and you check by hand. Another is called computer-aided semen analysis. The problem with computer-aided semen analysis, in my experience, is it's just highly unreliable. Now there's debate about this, and it's something that you could go off on an entire episode to talk about. But we used it in our practice for a while and just found it was just very, very unreliable. So we've moved to pure manual counts on everything. And it is analyzed in a high complexity CLIA certified lab. So everything is done, by the book that way with it. Now there's a couple ways they can do it. The simplest way is the patient gets the kit at the time of their vasectomy by their provider. So basically, if you're a provider doing vasectomies, the company just sends you a bunch of free kits. They sit in your office. When you send out the patient, you send them out with their post-op instructions, and then you send them out with one of these kits. And then when the time comes, the patient just opens up the kit, collects. There's a QR code in there that they scan. And then that basically has them fill out their information, their email address, things, so we can send them results. And then they have to pay the $25, which is the total cost of the collection and the test for them. And then the sample's mailed in, the results are sent to the clinician by fax, and then the patient's notified that results were sent. Now, we don't send the results directly to the patient just because the physician may want to, or the clinician may want to, look at the results and make a determination before calling them. But so basically the clinician gets those results. So again, total price on that's, $25 for it. So by far the lowest cost out there for something like this. Option two is a provider can actually purchase the kits directly from Pathright, and they basically buy them at $20 each, and then they can sell them for whatever price they want if an office wants to sell this out of their office. And again, the same concept, patient collects, they scan a QR code, the sample's mailed in, and the results are sent, very similar to how option one was. And then finally, option three, the patient can actually purchase these online for $40. The kit is shipped to the patient. In that case, the patient collects, mails it in, the results are sent to their clinician if the patient indicates. So the patient can say, hey, I want this sent to my provider. Here's their information. And of course, it's sent to the patient as well in that case. So all three of those are options and available. It just depends on, the clinician's desire for how they want to have this done. Now, just FYI, this is real high level. There are a couple other options out there, but these are probably the three main ones. Fellow is another brand that has a post-vasectomy test. As of the time of this and their website, it's selling for $149, and it uses computer-aided semen analysis. So I put those in red. Again, that's my opinion on this, as far as the computer-aided semen analysis, in my experience, just isn't as good or reliable compared to manual assessments. And then SpermCheck, this is available for purchase at places like Walgreens or CVS, things like that. That's $70. This one uses a different mechanism. It uses a chemical reaction to try to determine how many sperm there are. The challenge with this is it can't meet the AUA's criteria, where you're looking for 100,000 non-motile sperm or less. And so it does have some limitations that way. It is a legitimate therapy or a legitimate way of testing, but it doesn't have quite the potential, reliability, in my opinion, compared to someone looking at every single one of these tests themselves. And then SnipCheck, again, it ranges from $20 to $40 depending, which option you pick. It is a manual assessment, so it is an individual technician going through 50 screens, and it is a high complexity CLIA certified lab. All right, so if interested, you can just email support@pathreatmedical.com and say, hey, I want a whole bunch of these welcome kits. Just mail it out to me. They send it to you at no cost. You can do demos for RestoreX and things like that as well. You just let them know, and they'll send them out to you. And then, of course, there's more information as well at snipcheck.com. All right, next, jumping to penile meter. So this was because for me, I was just frustrated as a clinician because it's so hard to get good penile measurements when you're doing things like Peyronie's disease, and you want consistency, especially if you have multiple people who are doing these assessments. You can get dramatic differences between people because one will use a different ruler, one will push a different amount, all sorts of things. So if you're trying to get good data, you want good, reliable results. So we developed this ruler, and basically you can see, I think my mouse is showing up, but you can see that you place this against the pubic symphysis, and it's wide based so that you get a good, reliable, consistent measurement each time. You push in all the way to the pubic symphysis, and basically the penis is like straight up on stretch as you're doing this. And then once you have that snug against the pubis, then you bend it down, 90 degrees. So it's kind of going between their legs, and then you measure the penis against it. And I'll have a picture here in a second that will kind of highlight that a little bit. And then there's a girth ruler as well. We found that there really aren't any out there that allow you to measure girth reliably. So this can wrap around the penis, go through this hole, and then you can get a nice, reliable measurement from a girth standpoint. So there are just some helpful instruments there. Again, all those are available at pathreatmedical.com if interested in them. So you basically place this firmly against the pubic symphysis, and that's being shown here. Pull the penis out as far as you can. Now, typically patients are laying down when they're doing this as opposed to standing up. And so then you can reflect the penis down about 90 degrees and then get a good, reliable, consistent measurement. And as you can see here, so this is pushed against the pubic symphysis. Usually the measurement to the corona is most reliable. So here it's about 13.5 centimeters and then 18.5 to tip. Tip tends to be a little less reliable than the corona. And it's got a see-through ability, so you can get the measurements really accurate as you try to dial things in. All right. This is one that I'm actually probably the most excited about anything that we've ever released or developed. And it's brand new. So it literally just came out, a few weeks ago. And so we're real excited on this one. It's called Peyronie, or we call it Peyronie's gene. So Peyronie's has been around for as long as, we have records essentially, at least thousands of years. But the diagnostic criteria, surprisingly, have always been essentially just based on clinical diagnosis alone. You look at the penis, it's bent, and you say, okay, that's probably Peyronie's. And it really hasn't changed much at all. So with that in mind, I'm going to do a real quick interlude just to talk about something that we recently published maybe about a month ago or so in Journal of Urology, looking at new definitions for Peyronie's disease. And again, in my opinion, and again, it's self-serving because we developed it, but I do think this is one of the most important changes to Peyronie's in the past 50 plus years, because Peyronie's has never been adequately defined. If you look at all of these examples, so you've got a 24-year-old with a mild, gently sloping curve. You move down, you've got a 63-year-old with worsening of disease for 2 years, ongoing pain, calcified plaque. All of these examples would be classified similarly using the current, the prior nomenclature. And, acute versus chronic, that's variably defined in the literature, anywhere from 3, 6, or 12 months. You can have a 62-year-old with an overnight curve, never had pain, it's been stable since onset, and he's 5 months out. And you can have a 70-year-old with a new disease that happens after 5 years of prior stability and more. The first guy in this example is classified as acute, while the others are classified as chronic. And the nomenclature and system that we use is just inadequate. And then it really has a tough time defining Peyronie's versus non-Peyronie's. So you've got a 40-year-old who gets a knife injury to the penis and it scars. Is that Peyronie's disease? I mean, probably not. That's an injury. That's scarring that happens with an injury. You've got a 20-year-old, no prior curve, and he's got a real mild lateral curve since puberty. That's probably not Peyronie's disease, but it could be classified as it. And then you have a 65-year-old, mild repetitive trauma during intercourse, eventual deformity. That's almost for sure Peyronie's disease. And so all of these currently would be classified similarly. So a lot of limitations in the current classification system. And the problem, if you don't have a good definition, is you can't really define the natural history. Like, how is this person going to behave versus that one? It's so heterogeneous that you get this big blanket set of recommendations and counseling that just isn't accurate to everyone. It's not very customized. And how do you diagnose it? How do you define a customized treatment regimen? How do you do research on these? So you really can't going about curing something if you can't even classify it. So the very first step in any disease is getting a good classification system. So clearly there's a huge need for a change in the current terminology. And so we presented this, which was basically a labor of love study. It required over 5,000 statistical tests until we got to some final definitions. Took forever, but it was kind of fun at the same time, putting it together. But it creates this new classification system. And basically, you can see Peyronie's men would be classified as these men, whereas non-Peyronie's would be these men. And we'll go into each of these in a little bit more detail. So it does differentiate Peyronie's versus non-Peyronie's. It does show that you can have trauma with either, but it's not necessarily going to be Peyronie's disease because of trauma. Again, the knife wound example, you get stabbed in the penis, you're going to get a scar and you're going to get some deformity. That's just normal. That's not Peyronie's. Peyronie's is a hypertrophic scarring or an abnormal scarring that occurs compared to non-Peyronie's. And then you can have some types of Peyronie's disease that will overlap, but some that don't. So you can have a man who's calcifying and gets relapsing remitting, but classical won't have any of those other features of those other subtypes. So if we look at the non-PD curve definitions, so these ones, congenital, these are men that have deformities that occur since birth. And so hence it's a congenital etiology. It's not acquired, it's been there forever. Maturational, these are guys who are getting this pretty much during puberty. These are the ones that say, yeah, I've always had about a 10-degree left curve or a 10-degree right. We, clinically, we think this may be masturbation-induced type curvature, but we don't know for sure. But this is the real mild, usually lateral curves that are present for, pretty much since puberty. And then trauma-induced, like we said, is knife wound to the penis, gunshot wound to the penis, and some other injury to the penis. Now, this is different than Peyronie's because sometimes Peyronie's can be started because of some trauma, but Peyronie's is a hypertrophic scarring. It's too much scarring that's going on versus those other injuries are just related to the injury itself. So now if we look at the Peyronie's disease side, you can have classical. So this is Peyronie's that don't meet the other criteria. So, that's kind of a diagnosis of exclusion in some ways. But if we look at these other criteria, so progressive, these are guys that continue to get worsening of the disease 3 months or later after onset. So it continues to progress. Now, and I actually took out the slide that follows as far as where does 3 months come from. There was just a lot of statistical tests that showed that 3 months is the best time to make this differentiation of progressive versus not. So then calcifying, of course, these are guys that the disease calcifies. So they get a shadowing or a large plaque with calcification. And those who have real minor or minimal calcification wouldn't fall into this group. And then relapsing remitting, just like other things like multiple sclerosis, if the disease comes and goes or it reactivates after a period of time, so 6 months of stability and then it reactivates, these guys would fall into this relapsing remitting group. Now, all of this was done, and this is just one of many, many, many studies that looked at, or many, analyses that we did to try to find clusters. And you can see that these different subtypes that we selected really do differentiate themselves from other types. So red means that this is a very distinct group. So you can see these congenital men are very different than non-congenital men. And these classical Peyronie's men are very different than non-classical men. Calcifying are very different than non-calcifying. Progressive are very different than non-progressive. And so you can see these clusters that stand out. So this just verifies that this concept is probably a legitimate and good one. Now, what about active versus stable? So not surprisingly, there are different criteria depending on the Peyronie's subtype. And this helps explain a ton the variability in the literature out there. Currently, you'll get some studies that are reporting stability at 3 months and other studies that say it's not stable until 12 months. And it's probably because they're enrolling different types of Peyronie's men. So with the new definition, active Peyronie's is those who have a penile condition where the curve and other deformities are still actively changing, period. Whereas chronic it's stable. So if you have classical Peyronie's disease and you're stable for at least 3 months, you can call yourself chronic at that point or stable. Whereas non-classical, you need at least 12 months since the onset and no active change for 6 months, or at least no active change for 6 months. Either of those in a non-classical will be appropriate. Okay, so with that interlude in mind, that highlights the complexity of defining Peyronie's disease. With that context, Peyronie's gene now becomes a really important study. Because again, with a clinical diagnosis, you don't know, is this heritable or not? Are my sons going to get it? What's the risk of my brothers getting it, and so on? Can I predict the subtypes of disease? Can I tell if you're going to be progressive versus non-progressive? Can I predict the outcomes of treatment? All right, I'm in this subtype of disease. What's the likelihood that I'm going to have a good outcome of one treatment versus another? And again, do I even have Peyronie's disease? Is it more of a congenital or trauma? And that can cause, or is it just anxiety, that I don't really have any penile abnormalities at all. I just have this penile dysmorphia type condition. And again, what's the natural history going to be like? So all of those are major limitations, and all of those are potential areas where a genetic test may have a potential role. So we developed the first genetic test that evaluates for genes associated with Peyronie's disease. And more information, you can go to peyroniesgene.com. You can do all the ordering from there, anything like that, if you ended up wanting to order that test. Now, this is just one of several SNPs, and this is our preliminary data on things, but we have much more data and many, many more controls that are available in different series that you can populate here. And this is just one of the SNPs that are tested from a genetic standpoint. But so just to walk you through, in case you don't do a ton of genetics, is this is homozygous for this allele. So you get two alleles, one from each parent for things. And so you've got homozygous for this, meaning both of them are this allele G. This is homozygous for A, and this is a heterozygote. I've got one of each. And you can see with this particular one, these men, all of them had Peyronie's disease. All of these men did not have Peyronie's disease. And now, again, there's data out there showing literally thousands of people, in these areas that show that controls behave this way. But the Peyronie's men are very distinct on this. So it's a very strong positive and negative predictive value for Peyronie's disease based on, these data. Now, logistically, the patient or provider can go to peyroniesgene.com, download the form that you have to fill out. It does require a physician or a clinician signature. It requires a prescription, basically. And then that can be uploaded to order it. Once the kit arrives, these are the instructions. The patient gets this, the sample container, they swab the inside of their mouth. They then send it, ship it in, and then it gets analyzed and results are sent back to the clinician. And then again, just like the SnipCheck, the patient is notified that results have been resulted. Your clinician has the results. They'll be contacting you, and then the clinician can reach out with that info. All right, just one last slide on future plans. This is real high level here. We're in the process of doing additional studies on Peyronie's gene to decide, can it do a lot of those predictions that we talked about earlier? Can it predict who's going to be which subtype, what your natural history is going to be like, things like that? So very early, I think within a year or so, we're going to have a lot better data. We're also hoping to get something accepted at AUA to be able to present the preliminary data we already have showing its ability to detect different subtypes. We also are going to continue that study on the multi-center randomized controlled trial looking at RestoreX post-prostatectomy. We should have a lot more data. Again, the preliminary data looks like it's matching what the other study showed as far as the post-prostatectomy one. There are some new accessories that are going to be rolled out for RestoreX, really even in the next couple months, that will make it easier and enhance things. And then we have a new major announcement, bigger than any of the things I've mentioned so far, including RestoreX, that we anticipate in 2025. I can't give more details than that right now, though, but it should be a real major innovation. And as the launch gets closer, we'll do some announcements. I suspect it'll be either be AUA or SMSNA where we'll make the announcement on that. And with that, I'll thank you for your time. I'll go ahead and stop sharing my slides, and happy to take any questions or anything you'd like. So thanks for your time.
Well, that was really great. Wow, I got to unpack everything myself just to come up with the questions. But anyway, if you have questions in the audience, please submit those over the comments. Lori, I'll be reading those off. First of all, I'm going to say 2025. I think I'm going to see a reappearance on UroNurse also.
It'll be a cool one. I have to say, it'll be a really neat one. It'll be a big disruptor for sure.
Yeah. I say now that you got us all tempted. So on this Peyronie's gene, now this is something I've never heard of before. So it's interesting. The allele A, does it have to be expressed from both parents, or is it just if you have one parent who has it, then you're going to have Peyronie's? Or
yeah, and that's the tricky part. Like genetics, when you start getting into it, it gets real muddy real fast. And so we actually test multiple SNPs. That particular one I was showing, the guys who had both, So who had that same gene from mom and dad, because you can, women can get Peyronie's disease or an equivalent. It just happens of the clitoris. They never notice it because you're not, looking at that area. But so if they got that gene from both, so far based on that data, 100% of them went on to develop Peyronie's disease. Whereas if you didn't, if you only got it from one, it appears that you don't develop Peyronie's disease. Now it's trickier than that, because some of the other SNPs showed that if you were homozygous for one of these other SNPs, so you have both copies of this one protective one, you will certainly, no matter what, not get Peyronie's disease. And so there's a little bit of, you have to combine all of the different data together to say, okay, and in the end, what will happen is you get a report that says, this is a 96% chance that you have Peyronie's, or that, that this is associated with Peyronie's disease, meaning that the positive predictive value is rarely 100%, that if you have this test, 100% of the time it's accurate, there's no false positives, things like that. But what's interesting in some of these other SNPs, we're seeing that it can differentiate progressive men, which is a worse outcome Peyronie's type. And so you could say, well, I already know I have Peyronie's, why would I get a test? But if you know that, all right, this is going to help predict what's going to happen to you, and hence perhaps from a clinician standpoint, I say, hey, you're in this group, we need to get you on NSAIDs more, we need to do steroid type injections, things like that, things that are a little bit more out of the box to help prevent it from becoming as bad as it would otherwise. I think that's where in the next 3 to 5 years, we're going to see the real, utility of this. So, and then from a clinician standpoint, all the time I get guys coming in who say, I've got Peyronie's, and I try to convince them saying, you don't. It would be so nice to have a test just to say, let's do the test and show that, hey, this test now is much more conclusive that, look, you don't, and so that type of thing, I think there's some utility there.
Yeah. And that's probably another question to throw out to you, because this is your specialty. Men kind of obsess over what the perfect penis is. So I think that there are a lot of patients do come in thinking they have Peyronie's because they see a slight curvature. In your opinion, I mean, this is something pretty normal to see a slight curvature in most men, correct?
For sure. Yeah, nobody's done a good, and actually that's interesting, because I think you could actually do a good study on that. But and I'm sure nobody's done a good study looking at the true epidemiology of what we would define as maturational curve, where there's that 10 degrees slight left, 10 degrees slight right. I suspect if someone did, it would be like 70%, of the population will say, yeah, I had a real tiny, slight curve. That's very different than congenital. Congenitals are like the 90 degrees down guys. And then Peyronie's, like yesterday I was totally normal. Today I've got an 80-degree up curve. Those are all different groups.
Yeah. Lori, any questions coming in? Do you have any questions?
I have a question. Maybe I missed it. For the gene test, what's the cost on that test? Or
I think it's $200 if I'm not mistaken.
okay.
So I think they do the gimmicky $199 or whatever, but I think it's $200 for it. So
okay. I think I may have missed that part, but no, I think these are great. If you go back to the SnipCheck, as I was thinking about that, it's great that men can do it at home. It's just that area where now that the AUA guidelines are saying that these rare non-motile sperm are considered negative, I think that's where it gets a little hairy.
Mm-hmm.
I lost my train of thought. I'm sorry. Come back to me.
That's right.
I'll think of it.
Non-motile sperm is what you were referring to?
Yeah. Oh, yeah. Obviously,
dead sperm on an account.
You're not going to be able to get motile, obviously, out of these results. And is there a time frame for these kits that have to be returned by a certain time? How does that work?
Yeah. No, yeah, we haven't published it, but we actually, with our vasectomy reversal ones, we had one that got lost in the mail for 2 months, and that you don't get degradation of sperm. You'll get more bacteria that grows in there for sure, but you still see the fully formed, the tail, all of that side of it. And you're exactly right. As far as the non-motile, and that's a limitation, for example, with that other over-the-counter one, because it's just a chemical test. You can't tell anything. But what you can tell with a test like this is most cases, the answer is going to be 0. And so 0 is cleared. And then usually what happens is, let's say it comes in where we do see 50,000. So it's below 100,000, meets AUA's criteria, but you can't tell is it motile or not. Savan Hilo is working on a study right now just to see what's the likelihood, if someone has 50,000, what's the likelihood of that being motile in a sample when you look at it. And the results on that, again, we'll see what the data ends up showing. but it's extremely low. And so the AUA is just in the process of updating the vasectomy guidelines. So we'll see what the new recommendations come out as far as, are they going to still be real stringent on that 100,000 non-modal or not? The difference there, though, is in this case, let's say you do get a result back at 50,000. The thing basically says, we'd recommend, either repeating this or getting an in-person one type thing to the clinician. Now, the clinician ultimately gets to decide. They say, no, I read Savon's data. I know that this is almost guaranteed zero. Maybe let's do one more. If it still shows the same thing, we'll clear you. That's kind of at the clinician's discretion to decide there. But certainly if you see one that says 30 million, that says you can't be cleared, no matter what. And so it definitely, the far, far, far majority come back zero. That smaller sliver where you see that borderline area, that's where you'd either need confirmation. And you'd likely do that anyways in a clinical practice, with or without mail-in. So.
Right. Thank you.
Yeah, good question.
We do have a question. I was trying to ask Amy. Maybe she can. She said, "How about injection for PD?" And she was talking about Peyronies. I don't know whether she's talking about Xiaflex. I was trying to.
Yeah. When you look at what are the most effective treatments for Peyronie's disease, like if someone comes in and says, "Hey, I'm 80 degrees and I want to be 10 or 20," you're looking at either surgery with or without traction, and you're looking at Xiaflex with traction. Those are kind of your two gold standard therapies right now. Anything beyond that generally has negligible benefits. Even if you just did traction alone, you'll get improvements, but you won't get down to 10 degrees, for example. It's really these combination therapies that do the best. So when you look at that injection line, prior to Xiaflex, we had interferon, we had verapamil, we had steroids, we had hyaluronic acid, things like that. None of those were great. They were the best we had, and hundreds of men were getting these injections at any given time. But thousands when you talk about around the United States. But in a clinical practice, you'd have hundreds of these injections coming through, but they weren't very effective. Once Xiaflex came out, now you have an actually effective drug. But it has a lot of side effects. So it definitely gets men, when you do it correctly, it gets men significantly improved, works very well, but it bruises. And so you have to be real regimented in how you manage this, post. The other ones, verapamil is still used occasionally. It's definitely fallen way out of favor. The data on it shows that it's no better than placebo. So you can certainly do it. And some men swear by it. Some practitioners swear by it. But the data would not support a significant benefit to doing verapamil. Interferon is no longer available. You can't buy it anywhere in the world right now. Who knows why? It's just not, it must not be profitable enough for companies to make it. And then hyaluronic acid is becoming more popularized, particularly in Europe, because they can't get Xiaflex. Or they can, but it's not sold there by the company. And so they're starting to look for alternatives. So they're doing this hyaluronic acid injection. That's like the lip fillers, that they do. And so it probably helps with curve more so because it balloons it. So if you have a curve like this and you inject, it's then going to kind of balloon this open as opposed to truly, treating the curve. So those are all options. Steroids have kind of fallen out of favor for various reasons. And people are looking at new novel injectables, and they'll continue to roll out over the next 10 to 20 years.
Yeah.
A question about the RestoreX as well, post-prostatectomy. That's the study or the trial that you guys are doing. How soon are they trying to use that post-prostatectomy? Because I would assume that most men probably wouldn't want to.
Yeah, too soon.
Use a device too soon. Yeah, right.
Well, when I did the first study, so we started the first one at Mayo. We did a randomized controlled trial. I think, I want to say it was 110 we randomized. I can't remember the numbers offhand, but got data back on like 80-ish. I was afraid of pulling apart an anastomosis because they do the surgery, they suture the urethra essentially into the bladder neck. And the last thing I wanted was, one of the providers at Mayo coming up to me and saying, "You ruined, my repair." And so we said, let's start at a month. So we don't have any data on people starting less than a month. I do suspect you're best off starting immediately, but I think the trade-off of the damage to potential continence and things like that just isn't worth it. I personally don't think it would actually cause any of those harms. I don't think it'd be a problem, but we don't have any data to support that. And I don't even want to poke the bear, So we had them start at a month, and then they continued until 6 months. We found that you did need to do it daily, though. If you were very hodgepodge about it, you didn't get the benefits. You had to do it on a regular basis. And we looked at separate open label arms where people could then choose to do it or not at a certain point. And we found that you did better if you started earlier. So guys who started at 6 months tended not to do as well compared to those who started at 1 month, but you could recoup some of the benefits. So if you did start at 6 months, you could regain some of the kind of the more permanent improvements compared to if you started or compared to if you didn't do it at all. Now, once you start at like 2 years, 3 years, you probably can't recoup benefits at that point. Things are just, too set in stone. So
Thank you.
Do you have any thoughts on why the stretching improves erections post-prostatectomy? We've had patients, we would put on VEDs all the time just to try to get rid of the complaint of my penis got smaller.
Yeah. No, yeah. At first we thought it made no sense at all. And so again, we almost didn't publish the data, but we saw in the Peyronies study, we did a randomized controlled trial in diabetic men. We saw erection improvement there, and we saw it in the post-prostatectomy. And so Wayne Hailstrom did two good studies. Brock's group did a study many years ago that looked at traction and showed that you do see actual molecular mechanisms that happen. So you see an increase in MMPs, which are natural collagenases that break down things. And so you do see things happen. Hailstrom's group did a really good study where they looked at traction and specifically looked in a post-prostatectomy model in rats and looked at what happened. And you see an increase in nitric oxide synthase. And that's the most important, well, arguably the most important, mechanism for causing erections. And my theory on this is what happens, and basically he showed in his study that the rats who didn't get traction had a much lower rate of this compared to rats who did get traction during that recovery period. So my theory on this, my best analogy I've thought of is like, if you have a building full of workers and the power goes out and you don't restore the power for 6 months, those workers are going to leave and, not going to come back because they haven't been able to do anything, the whole time. Whereas if you restore power right away, they're going to keep doing their work until the normal power lines are restored. I do think the machinery of the penis, there was a good study done years ago by Iacono's group where they biopsied the penis at intervals post-prostatectomy, and they showed progressive scarring of the mechanisms that cause erections. So I think if you can maintain that function while waiting for the nerves to grow back of whatever they're going to regrow, then when the nerves do regrow, the workers are still there. The function is still there and can be recovered. So I do think it's a legitimate thing. And again, even this new study, as I've looked at the preliminary data that's poured in on 40 plus men at this point, we're seeing the exact same results as we did in the Mayo Clinic randomized control trial. So it looks like it's a true and legitimate thing.
You think some of the shrinkage that men complain about is the fact they're not getting erections after prostatectomy?
It's funny. That is a great question. You could do a whole episode on that. In our study, we did look at guys, did they truly lose length? And to my knowledge, this is the first true randomized controlled trial where we tried to see, did men post-prostatectomy? Now, there are some other prospective studies that looked at this, and they've consistently shown that it looks like men don't actually lose length. But no question, perceptibly, men say, hey, I've lost length.
Yeah.
No doubt. And I think it is both the erection, but I also think that suprapubic area a lot of times becomes more saggy. And so I think not only are they losing girth, are they losing kind of the internal robustness of the penis, so it looks smaller to them, but the top part is now becoming more saggy. And so when you look at your horizon perspective, it looks like it's smaller as well. But when we did true stretched lengths on these guys, we did not see a difference in outcomes. And other authors have shown a similar thing.
Okay. That's good. Another question I had going back to the Peyronies, you said the Xiaflex and the RestoreX together had the best results, correct?
Mm-hmm. Yeah. And
so
that
what's
was
the protocol for doing that? Because I know you can't start stretching the penis right after injection of Xiaflex.
We actually have them start about as soon as they can. And so typically it'll be about day 3 where we say, hey, you really should start stretching this if you can. Now, if they have an open wound, like an open skin sore or something like that, then we, say, wait until that heals before you do anything. And we say they have to push themselves a little bit because it's going to hurt, But Xiaflex, you correct it, you get it straightened, you get a 50-degree correction. If you do nothing, the body's just going to re-heal that because every wound in the body, it tries to contract things. So you got this nice, good correction. and then the body's going to try to just reheal that. So if you don't do traction or something to kind of keep it open or keep it improved, you're just going to lose the gains that you potentially had with it. And so in that study, the reason I like that one too was that one was completely done by people who had nothing to do with RestoreX at all. It was all the measurements were done like by the nurses, for example, or other clinicians or whatever the case, but people have no relationship. And it just showed that truly it did make a difference curve-wise, length-wise, things like that. So it probably it keeps that door open while it's waiting for the clay to solidify, Yeah,
very good. Lori, any questions coming from the audience?
Nope, we're all good here.
All right. So I don't have any other questions that I could think of, except make sure that you come back and tell us what's going on next year.
I'm excited to.
Now that you've teased us with it, we got to know.
It'll be neat, I think. Real excited about it.
Yeah. So this is really great. I mean, there's been a lot of changes. I didn't know what to expect when we were talking earlier, and really this is fascinating stuff that came out. So it's always fun to have you on the show because you never know what we're going to find out. But that's part of the joy of UroNurse is getting to learn new things that we don't expect to see. And speaking of that, next week, here's a little promo for the next week's show.
Recent reports indicate that syphilis cases have increased in the United States. This module provides an overview of syphilis transmission, symptoms, and stages. The speaker, Laurel Robinson, DNP, provides the most recent diagnostic and treatment guidelines. Additionally, she discusses high-risk populations and health disparities pertaining to the acquisition of syphilis. This presentation offers 1 contact hour credit. Join us next Saturday at 9 a.m. Central Time on UroNurse.com.
Yeah, nothing says Merry Christmas like syphilis, right?
I like the term acquisition of syphilis. That's a great description.
It's interesting because I have a lot of friends that will tune into the show. They got to figure out what Vic's up to. And somebody had picked up on one of the shows that we had talked about sexually transmitted diseases. And we had a Christmas party recently. No, it was actually Friendsgiving. We haven't got to Christmas yet. That starts today. Anyway, she said, I didn't realize that the STDs were on the rise in the nursing home.
Yeah.
Yeah. So something to look forward to, I guess, right? So anyway, I thought it'd be a good one to do. I will make a comment. Next week's episode, you will not have to register for like normally because I'm going to be pre-recording that episode as I will be out of town and unable to get to a computer. My 2 grandchildren are going to be running in the national track and field meet. So it's going to be, we're going to go see that since it's close by. It's in Indiana. So we're going to go watch them run. Probably freeze out there too, because it's running outside, but there's no way I can get a computer. So I did pre-record that one. But again, thanks everybody for joining the show, and we'll see you. Well, I won't see you live next week, but you'll think I'm live. Anyway, thanks again. Have a great rest of your day and great holiday, and see everybody soon.